First, I would like to thank the organizing committee, especially Dr. Azhar and Dr. Asim, and of course all the RIC team for taking care of me and invited me to join this meeting. For the past 2 days, it was fun with a lot of young guys, and then all over the specialty, not just cardiology, but also there are radiologists and neurologists from all over Pakistan. Oh my God, I have to stand. It really shows that I'm from Southeast Asia. I'm a bit. I have to stand on the couch. I'm honored. Sorry, I'm honored to be here. This is my third time in Pakistan. I was in Lahore before 2 times, and in Lahore General Hospital. The evidence is very clear. So in 2007, this paper is in 2007 showing a review of revascularization has a strong correlationship with a good patient outcome. And another analysis shows that among the method of revascularization, mechanical thrombectomy is one of the best options. So IV is overall less than 50%. Highest recanalization is still mechanical. But this is the all based on many old studies, which is do not use a lot of stent retriever or aspiration. They use more pharmacological thrombolysis. But what I want to emphasize is the recanalization rate is highest with mechanical, and revascularization will give good outcome for the stroke, acute stroke. As you're aware, IV TPA based on the 1995 NINDS trial, and then start with 3 hours and extend to 4.5 hours. But there is a lot of changes in the imaging, especially because from the imaging you can select the patient much better. So this is not because I'm a radiologist, but I want to emphasize that it is very important to have good imaging for you to select the patient. And with advancement of the endovascular tools and devices, and with improved techniques, especially with the endovascular technique, when we start to do coiling aneurysm, AVM, and other neurovascular treatment. Me, myself, also have initial experience of stroke thrombectomy using stent retriever, because when we do coiling of aneurysm, we have complication of acute stroke during the procedure. We don't have anything at that time, so we use the solid stent, which we are supposed to use for the assisted coiling to catch the clot. So and then we understand based on our own experience that mechanical thrombectomy is quite fulfilling, because you can catch the clot out especially during the acute stage. And we sometimes use the solitaire stand also to catch other things like a snare thing. If we have our coil dislodged, sometimes we use um, solitaire also to catch the cloth, the coil. And one of the most important evidence is the Mr. Clean trial. I think a lot of people know this Mr. Clean study showing that mechanical thrombectomy, especially using the device, is not worse than the previous study. So based on this, there is a lot of changes. There is a lot of changes in practice. Since there's not enough or not many interventional neuroradiologists, and the sudden surge of the need to treat the acute stroke give a lot of changes in the landscape of practice. So there are neurologists and some other specialty who have the capability comes in to help the patient. This is the 5 randomized study showing the positive result. I think you can go through yourself, but overall studies shows there is a significant benefit of mechanical thrombectomy. And based on this, a lot of societies started to adopt or put the guidelines. So you can, I think in the future, Pakistan also should have, or South India region should have own guideline for the endovascular thrombectomy in terms of patient selection, protocol, training, and so that everybody is clear what is the direction. Mechanical thrombectomy still focus more on the large vessel occlusion because of the bulk or the clot burden. If can be taken out mechanically, it will improve patients significantly. And then with the high clot burden, the surface area is lower compared to low clot burden, because low clot burden or smaller clot have a higher surface area, which might be more effective with pharmacological. And a lot of centers or societies combine to have other recommendation nowadays for the standard of practice. I think this is among the latest recommendation to triage the level of centers so that the calibration between the centers is more clearer and will benefit more patient, especially to reduce the time. I think some of the cardiologists are probably familiar with their STEMI pathway. So it might not be like STEMI, but it is at least there's some comparison to the STEMI. And there are 2 recent trials, diffuse and dawn trial, indicating in selected patient the time it is more than 6 hours. So this is the group of patient where you need a lot more understanding on the imaging to have a good patient selection, but it can go up to 24 hours. So especially good for wake-up stroke patient, where we are not too sure the onset of the time of the patient. So this is where imaging will be helpful to select whether the patient will have good outcome with thrombectomy. So there's a lot of devices, new devices coming up. And I want to highlight also the experience of cardiology in the mechanical thrombectomy. There are some papers actually use solitaire stent for the coronary work. And I'm not encouraging you all to use the stent retriever in coronary, but there are some people who have experience with this. With that, I still would like to emphasize the teamwork is very, very important. It's good to have collaboration with radiologists, neurologists, and others also, emergency physician. It is, yes, it looked like a little bit like a STEMI pathway, but it is slightly different. With that, thank you.